Hello guys, this is Dr. T speaking. Welcome to today's chat or discussion. Okay, so yesterday guys, we started this series on biliary tree pathologies. And we spoke about cholecystitis, gallstone disease. So we are continuing now. So today we are doing cholecystitis. So just a brief anatomy once again. I would recommend that before you come and watch this one, you watch the other chat that I uploaded yesterday on gallstones. So we said yesterday, because this is like a continuation. Remember, cholecystitis is a complication of cholecystitis. So that's why it's important to understand cholecystitis. So we said yesterday that, remember, the stones, they can be pigmented stones or cholesterol stones, but that doesn't matter now at this point. So now you've got stones. So you've got stones, whether they are cholesterol or whatever, whether they are cholesterol or pigmented stones. So you've got stones there. So these stones are there, they are sitting there. The patient is not symptomatic. So these are your asymptomatic patients. That's one. Number two, you can have these stones there and then incidentally someone finds them. Maybe they are doing an ultrasound for something else and then they become an incidental finding. Or maybe the patient went for operation for something else, but the surgeon saw that, okay, the patient has got stones. Those are incidental findings. Number three, when do they become symptomatic? It's when this one of the stones here come and obstruct the lumen of this, like I explained yesterday. So this patient will present with the right upper quadrant pain. They'll present with nausea, vomiting, anorexia, diaphoresis, maybe just generally feeling unwell. That's it. They won't have fever, and they won't have positive signs in the abdomen. They won't have gagging, they won't have tenderness in the abdomen, because at this point you can't even reach that bladder if you try and examine for that to elicit like a Murphy's sign, which we're going to talk about. You can try and elicit a Murphy's sign in this patient. It's not going to be positive because the bladder, it's not inflamed. So there's no inflammatory process in cholecystitis, but in cholecystitis there is an inflammatory process. So the reason why I'm doing this, I want you to understand now the difference between cholecystitis and cholecystitis. Here is just a stone obstructing, and this stone has got a potential of even falling back, and then the lumen or the duct becomes patent again. Then the patient becomes asymptomatic again. Now, what happens if this same stone now comes and obstruct further down the cystic duct, such that this stone cannot fall back? Why would a stone stay here and then fall back? When there's obstruction, the gallbladder will try and overcome the obstruction and try and push, because it knows that I need to get bile to the GI system so that I can be able to absorb those fats. So it will try, but the minute, as long as it tries, it increases pressure inside the gallbladder and pushes that stone. But when it relaxes now, that stone has got a chance of falling back when it relaxes. But if this stone stays there, first of all, this is now how, okay, let me just quickly say this. Cholecystitis can be acalculous. What is this I'm writing? It can be acalculous, or it can be calculus. If it's acalculous, it means that a patient has got cholecystitis, but there's no obstruction, there's no stone, or the obstruction is not the stone. So they say this accounts for about 5%, and then this is 95% when there is a stone, and the stone that causes calculus cholecystitis is gallstones. So it's important to understand gallstones. This acalculus cholecystitis, even myself, I don't understand it, because the risk factors, there are so many. It says that heart failure can cause it, error of systemic illnesses can cause it, major surgery can cause it, being critical, anything that can make a patient to be critically ill can cause acalculus cholecystitis. And I can imagine how hard it is to make that diagnosis of acalculus. The patient will present with the symptoms, but the only way you can see that it's acalculus, the patient will have all the symptoms of acute cholecystitis, but they won't have a stone that is obstructing the duct, or they won't even have stones in the gallbladder at all. So because if you see stones in the gallbladder, then it means that it's calculus, it's not acalculus. So for you to say it's acalculus, then it means there must be no stone involved. So I think I'm sure it's a very difficult diagnosis to make. But anyway, so let's talk about calculus. So I'm gonna do the physiology, the pathophysiology, so you can understand the symptoms. So you've got an obstruction here, and then that stone sits there. So number one, obstruction of the cystic duct. So once you obstruct, the next thing that's going to happen, you will develop stasis. There will be stasis. So there won't be movement of the bile out of the gallbladder. So there will be stasis. And once you have stasis, what's going to happen is that inflammatory mediators will be activated. Activation of inflammatory mediators, like your enzymes, your phospholipase A, but the most important one is your lecithin, or your lysolecithin. So once you have got these inflammatory mediators, they will cause inflammation. I'm sure at this point you can appreciate that you can have an inflammatory process without the involvement of pathogens like bacteria, and still have an inflammatory process. There's a study that I read that there were patients that were done cholecystectomy, and then they examined their gallbladders, and then they found that there was no bacteria involved. So this is the main mechanism that contributed to those patients having cholecystitis. Doesn't mean that once you have stasis, you have a risk, you run a risk of having pathogens involved once you have stasis. So your bacteria will contribute to the inflammation, your pathogens will contribute, but doesn't mean that if you don't have bacteria, you won't have an inflammatory process. You will still have, because of this. Okay, so, and then your patient now will have this, and what happens is when you've got inflammation of the bladder wall, those cells that line the wall, they will start to secrete a lot of fluid. And that fluid will cause this bladder to distend and become big. One thing that is going to cause them to, it's the fluid that keeps seeping in there and filling the space there. One. Number two, because the wall also is inflamed. The wall itself is inflamed. The wall itself is inflamed. It dematters the wall itself. So, and once you get that, the branches of the cystic artery, some of them will become obstructed, and then you will have areas where you develop ischemia. Once you develop ischemia, you will get necrosis. Once you get necrosis, if nothing is done, it will perforate. So let's talk about now the presentation. How will this patient present? Presentation. So the presentation can be, they can come in unstable or stable. Why would a patient with cholecystitis present unstable? This patient will present unstable. Once you perforate, necrosis, and you can easily run into SIRS here, systemic inflammatory response syndrome. And once you get to SIRS, you easily get to MODS, multi-organ dysfunction is a syndrome. But you can get into multi-organ failure because of the SIRS. It's very dangerous. So actually, this is how appendicitis patients die. This is how, like, small, the things that look small in the abdomen, this is how patients die. Once they get into SIRS, then they are in ICU, they stay, they need ventilation, they need positive inotropes. Because remember, once you get into SIRS, you're going to have multi-organ involvement. You start now having hypotension, and that means the heart is involved. The patient now, all of a sudden, they need Dopuytrex or positive inotropes to keep the heart pumping effectively, because now they're going to develop cardiogenic shock because of and then the kidneys kick in. Now all of a sudden you've got high creatinine, you've got high urea. All of a sudden we are looking at that, and then the patient, now you've got deranged LFTs. All of a sudden the brain becomes involved, the patient becomes confused, and that patient, it's gonna take a lot of work to save that patient, and a lot of divine intervention to save that patient. You don't want to get there. You really don't want to get into SIRS and all of that. So this is how patients die from simple infections. Because once you get SIRS, guys, you must go and read about SIRS and multi-organ involvement, multi-organ failure, and all of that. It's so important. Okay, so these patients will present unstable. They might present with the abdomen will be painful, their abdomen, like they will have like distended abdomen, peritonism, they'll have guarding, so they'll have signs of peritonism or peritonitis, and with abnormal, they might come in shock, septic shock, and all of that. But let's talk about the most stable patients now. So your patient would have had right upper quadrant pain, because this is where the gallbladder is. They would have nausea, plus minus vomiting, anorexia. If you look at these symptoms, they're not very different from cholecystitis symptoms, but I'll show you where these differentiate. When you get now to the abdominal examination, here you'll have a positive Murphy's sign. You'll have a positive Murphy's sign here. And what is a positive Murphy's sign? When you ask a patient to inspirate, and then you try and slide your hand under their costal margin, you will be able to feel a distended bladder. And then, because remember, when they inspirate, their lungs inflate and pushes down the diaphragm. The diaphragm will push the liver will push the gallbladder. That gallbladder is going to come and rub against your hand, then they will scream because of the pain. That's a positive Murphy's sign. So they will have that, but you don't have a positive Murphy's sign in a gallstone disease or cholecystitis. So I'm talking about patients now that are not peritonic, patients that are not peritonitic, patients that did not perforate. They might have necrosis, but they've not perforated. So you will have this, or you can feel a gallbladder mass as you push your hand. Therefore, there's something that is obstructing you. So you can feel a mass, and then when you do your bloods, remember, even if you think that the patient has got gallstone disease, you still need to do your CRP, which must come back normal for you to say it's gallstone disease, and do a white cell count. In this case, these will be high because we do have an inflammatory process, but in cholelithiasis we don't have an inflammatory process. So because here we do have, then these will be high. Your CRP and the white cell count will be high. This will be your blood. So that's your history. They will tell you about these symptoms, and then physical examination, and then your biochemistry. You will have those bloods there. And if you decide to do, you can do LFTs like ALP, ALT. They'll just come back normal to confirm that the right upper quadrant pain that you're having has got nothing to do with the liver itself. There's no obstruction. You can even do a total bilirubin. It should come back normal if you've got cholecystitis. But we are going to talk about conditions where you've got right quadrant pain or tenderness, and then you've got deranged LFTs. We are going to talk about those conditions, like in the case of cholangitis, because you've got obstruction there. Okay, so, and then you have imaging. So if someone asks you how do we diagnose cholecystitis, it starts with history. The patient will come with these symptoms, physical examination, positive measles, and also like I said, it depends whether they've perforated or not, because someone who's perforated will present different from someone who is not perforated. Then your blood, CRP. You don't use bilirubin to diagnose cholecystitis, but you are using it to rule out if you might be having any other pathologies, like also ALP. We are ruling out obstruction in the biliary tree, not that you are, but the most important thing that you want there, the most important thing is your CRP and the white cell count. And then when it comes to imaging, there are a few, depending where you're working and what part of the world are you working. The imaging for this is ultrasound. What do you see on an ultrasound? If you remember the drawing, we had a bladder that was big there, very big bladder. Your bladder will be distended. You will see stones here. You might even see a stone that is here. But if you don't see a stone here, you will see dilatation of this. And normally they say that this, if it's more than 4 millimeters, the wall, the thickness of this wall, because of the inflammation and the edema, it should be thickened. So it's gonna be more than 4 millimeters. And then you'll see stones there, and then you'll see a distended bladder. You will see a dilated cystic duct. Yeah, so those are the features on an ultrasound. And also there's what is called ultrasonographic Murphy's sign. So what you do there, you push a probe and ask the patient to inspire. Your probe, because now your probe will be here. The probe of your ultrasound, you will put it there, and then you ask the patient to inspire. Then that distended bladder will hit against or will rub against your probe. Then the patient will scream. That's called a positive ultrasonographic Murphy's sign. It's not really different from the clinical. So another thing that can be done is a CT, or they also say you can do a HIDA scan. Most of the times, people end here and take a patient to theater without doing CT and all of that. A CT maybe can be done if you are struggling to make a diagnosis from the ultrasound, but it's not really a requirement that it has to be done. Okay, let's talk about the Tokyo classification. Tokyo classification of cholecystitis. There's A, there's B, and then there's A, there's B, and then there's C. A is local signs of inflammation. B is systemic signs of inflammation. And C is imaging. So the Tokyo classification says that if you've got a feature on A and B, that is one feature A and B, then you should suspect cholecystitis. But if you've got a feature in A, B, C, then then definitely you do have cholecystitis. But what are the things that they look at? Local will be right upper quadrant, pain or tenderness or a mass. Systemic is fever and increased CRP and increased white cell count. As a student, classifications, they always make you sound smarter when you are being asked questions, even though it's the only thing that you know sometimes. So they always make you look smarter. I know there are people who don't care about classifications. I'm a person who cares about classifications because I think classifications, they make life simple. They make, like I said in our what you call author discussions, that classifications, once there's a classification, it means there's an immediate management for that thing. There's like a stipulated management of that thing once it has got a classification. It's like when you say someone has got a Colles structure. When you say someone has got a Colles structure, you are saying to us that it's an elderly woman, likely, who is in their menopause, who are post-menopausal, and they've got a fracture, and then they fell on an outstretched hand or wrist, and then they get that fracture. So, and the management, so basically is, you can't say, if you say Colles, to me, we are talking about someone who's old, the first place, someone who's got weak bones. By the minute you say Colles fracture, so I don't expect a Colles fracture on a 15-year-old or on a 25-year-old or even a 30-year-old. So when someone has, it's like a hemorrhagia. When you say hemorrhagia, you're not just talking about the forearm fracture, but you're also talking about the dislocation as well. Yeah? So classifications are helpful in that. So in these classifications, when you have these, they are also very helpful when we're not sure about something. You go back to them and say, okay, according to the Tokyo, okay, I've got my patient, let's look at the Tokyo. Okay, and then you start to say, okay, my patient has got tenderness, and then my patient has got a white cell count that is high. Okay, there are two features, so I should suspect cholecystitis. But if your patient doesn't have any of these, it's very unlikely to be cholecystitis. So look for other things other than sitting and saying it's cholecystitis, and when you don't even have any feature on these things. So they are very important. I know we are lazy to learn classifications, but they make life very simple. Okay, so fever, imaging, we said ultrasound, and we mentioned that CT or a HIDA scan, and we mentioned that a thick wall, dilated cystic duct, dilated, a distended gallbladder, and all those features. I'm sure there are others as well. So now the minute you've got one here, one here, one here, then that's definite cholecystitis. But if you've got none, then it's not cholecystitis. But if you've got one, suspect cholecystitis. So that's that. So remember, Tokyo classification. Now you have made a diagnosis of cholecystitis. Now what do you do? How do you treat cholecystitis? So the option here is operation. And operation can be done, it can either be open or it can be laparoscopic. So, and this depends on who's operating. There are people who would say, but there are so many factors that are used to decide whether it's going to be an open surgery or a laparoscopic. One of the things is, when a patient has got complicated, like a patient that is ruptured, you can't do laparoscopic on a patient that has got a rupture of the gallbladder, like it's perforated. You can't do a laparoscopic. that abdomen needs to be washed, and then look for other things as well, and just to make sure everything is fine. But it has got its advantages. One of them, there's less pain involved post-op. The patient goes home sooner, so the hospital stay is reduced, and then the post-op pain is minimal with laparoscopic. And then patients recover, they go to work quicker, that kind of a thing, they become functional again. But this one can keep a patient longer. The chance of sepsis is also very high with open surgery, and the pain that the patient will have after the operation, and they will take time to start mobilizing, they'll take time to go back to work, that sort of a thing. And also depends the person who's operating, which one do they want to do, and which one of these are they comfortable doing. So the operation is cholecystectomy. So guys, I hope you enjoyed that, and let's meet when we talk about we'll talk about the other complications of gallstone disease. Maybe we're going to talk about cholangitis or Meniere's syndrome. We'll see. Bye.